difficult to do a video on because it's really a blind procedure. I do have a disclosure to make. I am an orthopedic surgeon, and so I've heard him insult a nurse and an orthopedic surgeon, so hopefully you won't need a hip replacement someday. But so full disclosure, I am an orthopedic surgeon. Anyway, I think with exostectomies, you know, they're really good operations, but there are really only 4 articles out there that have addressed this over the years. And they start with Jim Brodsky back in '97 and the most recent one in 1998. And then, you know, 2 really good articles, one out of the Beth Israel program and the other out of West Penn Allegheny system. But when you actually look at the literature on this subject, there are only 97 cases that they've talked about, these 4 different centers. And they're all pretty experienced centers. And the interesting thing, when you look at it, they had 35 complications, which is a complication rate of 36%. So 1 in 3 patients end up with a complication, and they include wound problems, infections, osteomyelitis, and of course even recurrent ulcerations. But the bottom line is, once you get over the complications, about 71% of those ultimately achieve the successful result. And that kind of mirrors what I do in diabetic foot problems. You tend to have a lot of complications with what you do, but ultimately you achieve a high level of success, and you just have to recognize that going in. But, you know, I just wanted to share a couple cases, and this was a patient of mine who had type 1 diabetes for, 40 years and presented with, the lateral column ulcer, as you can see there. And what we did is we published an article in the last year about the lateral column and looking at the cuboid height, and you can see that the cuboid here is below the weight-bearing surface of the bone in the lateral column based on that weight-bearing area. That's a bad problem, and these ulcers, if you have one, will not heal. And if you have a patient with this bone that protrudes below the weight-bearing axis, they will ulcerate. So we're pretty aggressive when we see this type of problem. And so in her, intraoperatively, basically, I'm trying to make this nice and flat so that I create an area that's going to bear more weight for her, that's not going to be sticking below. It's kind of like an iceberg upside down, if you think about it. And in essence, what you're doing is, from a physical standpoint, you're trying to redistribute the force over a wider area. And when you do that, you'll lessen the pressure and get it to heal. Second patient, very similar patient, left foot ulcer, neuropathy. This patient had very well-controlled diabetes. And you can see that, again, they lost their talonavicular and their first metatarsal angle there. That should be a straight line. But the bottom line, you can see that the cuboid bone actually has negative cuboid height, we call that. It's protruding below that weight-bearing surface. Again, you're never going to get this ulcer to heal. If you can offload it, you might get it to improve, but it will recur if you don't do something about the bone. And this is just another example where we're using a mallet intraoperatively to simulate a weight-bearing film after we take the bone. And we're kind of doing this through a lateral incision, and really we're doing it not under direct vision, obviously, and we'll use osteotomes, we'll use saws, just to make it nice and flat, and then we'll use a rasp. The bottom line is we want to create a nice broad surface that's flat. Now the interesting thing I want to share with you, because I'm very interested in quality of life, and this is unpublished data, it's been reviewed at a journal and it's been accepted, but the bottom line is that Charcot patients have significantly reduced quality of life when it comes to their physical component scores, and that's what you can see there in the green. What's interesting to me and astounds me actually is their mental quality of life is almost near normal. It's 50 for normal patients, and theirs is close. And I'm not sure how to explain that, because these patients walk around with deformities in their foot, and we actually compared 2 groups here. One on the right is ulcers, one on the left is the others without ulcers. And the bottom line, the ulcer didn't seem to have an impact on their quality of life any more than the Charcot did. But so it profoundly impacts their quality of life from a physical standpoint, less so from a mental standpoint. And it's just kind of interesting that they don't have mental impact when they run around with a boot on for years and they have ulcers. But I think for an exostectomy, it's a well-proven technique in selected patients. I think it works about 70% of the time. It is associated with a high complication rate. It's a relatively simple procedure compared to reconstructing a Charcot foot. But you have to make sure that you don't take so much bone that you create an unstable situation. So that's the bottom line with these. I think it works well. It's a good option, and it doesn't burn any bridges. So if I have somebody with an ulcer like this, and I'm having trouble getting it healed, and I see that there's bone below the weight-bearing surface, I can go in there and and knock off that bone. I can get deep cultures, and then ultimately I can get that wound to heal. And if I need to do a reconstruction down the road, then I have a soft tissue envelope that's intact, and I think that will reduce my major infection rate down the road. And that's the bottom line. Thank you.